HCHB is proud to sponsor the Last Visit First podcast, which explores the complex issues faced by today's home health and hospice providers.
In the spotlight today, Chief Revenue Officer Hannah Pearson, explaining how HCHB uses technology to connect people.
One of my favorite phrases is relationship architect. The focus is about the client and building the right community, the right fabric of community around our customers, making sure that from the very bottom to the very top, they had a resource and a contact to reach out to with any problems, and that we could connect them quickly and expeditiously to the right resource. That's where the client success team was born, and we touch people at every level of the organization.
Well, good morning, good afternoon, wherever you're at. Welcome to the Last Visit First podcast. Today, I'm super excited to have these two gentlemen associated with this podcast as we dissect the 2026 final rule that came out last week. Let me start with introductions. So we'll start with Scott Levy. He's the Chief Government Affairs Officer for the National Alliance for Care at Home. So people know that as NOC, but we changed the name of it about a year ago now. Scott brings more than 2 decades of expertise in healthcare law, public policy, and advocacy. Most recently, he was on the government affairs team at Advocacy, or he led that team. He's been shaping the home care and hospice roles for many, many, many years. And Scott, it's an honor to have you on the podcast, and super excited to hear what you have to say about this today.
Thanks, Tom. Really appreciate the opportunity. It's always good to be with friends to talk about fun issues like this. So looking forward to chatting today.
Yeah, awesome. And then also with us is Luke James. Luke and I have known each other. We actually started on the exact same day when I started at Home Care Home Base. Luke started at Encompass back then. So Luke's the president of VitalCaring. He's the one guy when I was running Home Care Home Base that I always went to around policy, around are we getting the rules right? Are we getting the Medicare rates right? And all those kind of things. He's probably the industry's leading expert in this area. So we're going to use Luke a ton today to really dissect what's happening and what's going on in the real world of operations, as well as the CMS final rule here. Luke's been around the industry since 2005, I think, is when we both started, Luke. So welcome to the podcast.
Yeah, thanks for having us. Look forward to spend some time, as Scott said, amongst friends. And I guess, if you don't like what I have to say, Tom, it's on you, because I've learned most of everything I know in health and hospice and technology from you. So just have to look in the mirror there. But I look forward to spending some time together today.
Yeah. That's going to be awesome. I can't believe we're finally getting to do this, and hopefully we can get this out. It'll release on Thursday, and we'll jump all over it and see if we can't solve some of these problems. So let's start out quickly. Scott, dissect the rule. What immediately stood out to you around the payment, the structure, the PDGM recalibration? Give us your quick opinion, and then we'll jump to Luke on his opinion.
Yeah. We've been at this for this proposed rule since before it became a proposed rule, really trying to blunt any sort of cuts for next year. And, the proposed rule coming out at 9% was pretty drastic. So we had a lot of work to do. The biggest thing I think that this industry needs to understand is that this is the first time that CMS since PDGM was implemented, that they've made a shift. They didn't just cut the cut in half and then build up that temporary bucket. They made a meaningful shift by cutting those permanent adjustments from 4% to 1%-ish. That's not just an impact for this year. That's an impact into the base rate going forward. We've estimated roughly about $2.4 billion that came back into the system between 2026 and 2030 with that one change. So understanding that impact is huge. And also, they signaled that they might be done with permanent adjustments, capping the data years at 2022. So those are some really meaningful shifts that stood out quickly, but it's still a cut. So we understand that we're still at a year-over-year cut from where we were, but it's significantly different than how they've done it in the past. That was the biggest thing that stood out.
What about you, Luke? What stood out to you?
Yeah, I think I have to agree, Tom. I'll try to do that as little as possible today and have some fun. But really, and I sent Scott a text message as soon as I saw the rule, that it's not just that we received a benefit as opposed to the compared to the proposed rule of 5%. That's huge, right? That outcome, we still aren't happy with getting a cut next year. We don't think we deserve it. We don't think we should get it. There's still a lot of areas in this rule that we certainly don't agree with. But moving the needle from negative over 6% to just over negative 1% was huge. But my first question is, how did they get there? in the past, they've simply punted those cuts to future years on average, right? They're splitting a cut they say is needed and spreading it out over 1 or 2 or 3 or more years just to not put too much quote unquote burden on the industry in any one single year. We see that language put in a lot by CMS, and most of the time, if not all the time, when they are when the final rule comes out better than the proposed rule, it's not that they're giving us a break in totality, it's just that they're giving us a break this year. And so when I dug into that language, I agree that that's by far the most significant element of this final rule is how CMS is looking at really the calculation for permanent adjustments by year and really what that means going forward. So I'm excited to dig into that further, I'm sure today. And I think that the impact that could have on the industry in a positive manner over the long term is about the most significant positive development I've seen out of a CMS home health rule in quite some time.
I agree with you. The rule was 762 pages when it came out. I did a little bit of ChatGPT fun with that. If you're a speed reader, it took you approximately 16 hours to read the rule. So I don't know how many people on this that are listening to this read the rule. I didn't read. It didn't take me 16 hours because I skipped over a lot of the common stuff that wasn't important. But that's also a third of the size of the Bible. So if you read this entire rule in entirety, you could have read the Bible. Spent a few more hours, you could have read the Bible. I don't know how they wrote 762 pages. I mean, like I was blown away by that. When I first got it and tried to download it, I'm like 762 pages. Like, what am I going to do all weekend? It's pretty wild. Let's dissect the math. So the payment math. So CMS headlines at a 2.4% market basket update. I want you guys to explain this because not everybody really understands what that means. Yet most agencies end up with a roughly 1.3% net. Can you walk us through the math that they used on how they got to these cuts and kind of explain what they are, if you don't mind? And Scott, we'll start with you, and then we can definitely jump to Luke.
Yeah. So Tom, the way they do this every year is they project a market basket update using a data set that's put out by the BLS. Is actually 3.2% is what the market basket is. All the factors that they put in. And then it's reduced by a productivity adjustment, which is a construct that came into play from the Affordable Care Act. So that reduced our 3.2 by 0.8% to get us to 2.4, which we've collectively just uniformly called the market basket. But that's actually, the market basket net of that cut from the productivity adjustment. So we start at 2.4%. And then they have reduced us by the permanent adjustment, which was just under 1% from a I guess, annual payment cycle or expenditures. And then the additional 3% for the temporary, that's where we come, or it's 2.75, I think was the final number. That's how we get to that 1.3 net update, negative net update for year over year. So it's several different factors that get you there, along with the impact of the FDL being at 0.1%. So Luke, I don't know if you've got any more color you want to provide on that math. I'm a lawyer, so we don't do good math. So when you give us easy ones like this,
Yeah, lawyers, you like to turn math into words, and I'd like to keep math
That's
just as
right.
numbers, as a numbers guy. So, no, I think Tom, maybe going back quickly to your prior point about 762 pages. For any of your listeners that haven't, completely dove into the final rule yet and are scared off or intimidated by that number. I'll give you a stat that it's only through page 240 that you really need to read if you're focused on the home health industry. From page 241 until about 730 something, it's really about the DME elements that are included in the home health rules over the last several years. And so if you're not needing to dive into the DME related elements, then 240 cuts that number and by like a third. If you want to spend some time there, focus on those first 240 pages. But no, I agree with the math is the math. Scott just laid it out. I think a couple key things there are, there was a lot of comments and feedback from CMS kind of dialogue in this final rule around the productivity adjustment. That's getting to be a more and more controversial element that was mandated by law through the Affordable Care Act, as Scott said, back then, 15, 17 years ago, and has been part of the rulemaking process ever since then to kind of net out our gross market basket update that we get every year. But that number has grown, as Scott said, to 0.8 of a percentage point now, at the same time as our costs as an industry. We all know our labor costs especially are growing exponentially more than they were back 10, 15 years ago when that productivity adjustment factor was first implemented. And so that is taking a lot of money out of the system. in ways that if you read the comments in the final rule, there's a lot of disagreement, a lot of angst, and a lot of anger, frankly, that's being stripped out of our payment update because it's just not reflective of reality. And then the fixed dollar loss ratio, I think, is probably something that slips by a lot of people's radar. As Scott said, at 0.1%, that came down significantly from the proposed rule. Scott, I think it was closer to 8 or 9/10% in the proposed rule.
Either 0.5% or 0.6%. I think it moved by 0.5%.
Okay, so it moved by 0.5%. So those are big dollars, right? Those are big. We would have 1.8% reduction instead of 1.3 if they didn't move that number. And so it's kind of a complicated scenario there, but one I think that the industry, especially the Alliance, Scott and his team and others there, really I think probably dialogued very well with CMS around that number to make sure that it wasn't too big of a cut to ensure that outlier payments don't exceed 2.5% next year. So overall, that was a win for the industry and one that I think it took quite a bit of work to get there.
Yeah, let's break it down, the dollar impact per episode. So for a typical 30-day episode, nearly $2,000, what does a 1.3% cut equate to annually? And are there cases where agencies might see modest gains depending on their case mix or utilization or wage index? Luke, we'll start with you.
Sure. Yeah, those are relatively small dollar amounts, Tom, on a average payment period that you're going to get. You're talking $25 or so per payment period. So not huge dollars we're dealing with, but to your point, when you extrapolate that on the number of payment periods and patients that an average agency is going to treat next year, those can be big dollars depending on the amount of volume of patients that you're treating. I think the biggest thing it is swinging that from what we can see. Yes, some of it is case mix. If you look at the table towards the back end of the rule, you can see that certain types of providers, nonprofit versus for-profit, certain areas of the country, Northeast versus South versus West Coast, and others around the country are getting swings, up to about a 0.5 point or more difference, just depending on where you are in the country and what type of agency you are. On average, you're going to get a either worse or better by about 0.5% on average compared to the headline number of 1.3. But really, the one factor that's going to swing it the most is the wage index, and that's just a roll of the dice. It's a flip of the coin. Wherever you're at and whatever hospitals are in your region to determine what your wage index is and what they've reported on their cost reports 3 years ago, that's going to come through the rule by CMS is just an increase or a decrease in your payments. And, we're seeing across the VitalCaring space, we've got some that are capped at the 5% cut, which CMS has implemented in any given single year. And we've got some that are better by 9 or 10%. And so that, can wildly swing the ultimate impact that each of our agencies will incur as a result of this rule.
Yeah, I think that's really important to think about. And historically, over the years, they've always done this. And so if you're not diving deep into your CBSA code, which is the wage index adjustment, essentially it's the postal code. It's a breakdown of the postal code, and really diving deep into how that's going to impact you as an agency. You could think you're getting a positive or a negative cut, and you could be getting a positive or vice versa. You could get way a larger negative cut than you thought you were getting. So if you're not diving deep into that, please do. If you're not educated around it, call me and I'll help you around it. Some of the EMR vendors, Home Care Home Base being one, who's a sponsor here, they put out a pretty good analysis for you, so you can see where you're at today, where you're at going forward. I know WellSky's doing one and NetSmart as well. So that's an area you really need to focus in on and really look at the counties in which you service patients, what that wage index fluctuation is. Scott, I don't know if you want to add anything to that.
Yeah, not specifically to that, but just about how that area of the rule, when it came out, the proposed rule, how we use that from an advocacy standpoint. When we're on the Hill, the Alliance put out a lot of one-pagers this year for our Hill Day, and we had them on a state basis, but we also had them on congressional district basis. And so when you're able to show wage impact, the impact of the wage index on the rate, so I can show Congressman X or Senator Y that their district's actually going to be worse off than that national 9% cut. It's a really impactful advocacy tool. So I would encourage people, in these situations to really, like you said, Tom, understand what their wage index impact is, not just with that national rate.
Hey, Scott, use this as an example to, or an opportunity to tell people how, if they want to continue to be part of the advocacy efforts, and by the way, please don't stop. We need to keep going. We just got to cut. So we need to keep doing advocacy. How do they find, how do they get involved?
Yeah, first of all, join, be a member of the Alliance. We're a new organization that came together last summer with the the merger of NHPCO and NOC, but we've got a robust advocacy team and advocacy platform. Just go to the Alliance website. We're starting our membership drive right now. We have plenty of communities and councils that you could be involved in, but if you're coming to DC and you want to go meet with your congressman, we'll help you set it up. We'll help you with talking points, what you need to talk about, because we need to grow our advocates. We did have our largest ever fly-in day during the summer and the fall in September. It had 250 plus advocates come up. We want to grow that, and we believe advocacy opportunities like we just saw with the home health final rule allows us the opportunity to grow it, to continue to share the message. So just look us up online. Follow us on LinkedIn. We're pretty active on LinkedIn and X and Instagram. So we're putting out stuff every single day. Reach out to anyone on the team. We'll get you in.
Perfect. And what happened to the partnership? I know we folded that in, but tell me more about how you guys folded that in. Because it used to be an area that we really spent a lot of time on advocacy as well.
Yeah, and that's actually, Tom, where I got my first start in the industry doing advocacy. And Luke and I connected. I used to say we were the two guys in the room that that looked in a little bit of a different generation than most of the other folks, but people who really paved the way. But Luke and I would look at each other and be like, all right, help me interpret this. But the partnership, very valuable. But that group of members who are members of the Alliance decided that they were going to consolidate the efforts and come on board, and everybody have a unified front within the Alliance starting January, and it's worked out well for us, being that unified voice on home health. The membership's been great, and there's still a voice for the Medicare certified home health agencies, of course, at the Alliance. So that's kind of where things stand with the partnership.
That's awesome. Yeah. So thanks for doing that, guys, and thanks for that tidbit. And Cole, please put in the show notes. Cole's the producer of this podcast. He'll put in the show notes how to the website and things to get to the Alliance as well. So we'll make sure we do that.
This is Scott Beard, Chief Strategy Officer at Maxwell TEC. One of the biggest challenges in post-acute care is leakage, when patients leave your care and never come back, even when they need you the most. Many agencies hire staff to call patients after discharge, but the sheer volume means only a small percentage can actually be reached. That leaves gaps, drives up cost, and puts patients at risk. That's why we created nanaCONNECT Reach, a fully automated text-based engagement platform that follows up with every patient every time. Reach reduces the cost of staffing while delivering something no call center team can match: the automated reach of 100% of your patient population. Patients love the ease of texting, and agencies love the results. Engagement rates are consistently 30 to 40%, meaning patients are not only getting the messages, they're responding. With nanaCONNECT Reach, agencies lower cost, protect against leakage, and ensure no patient slips through the cracks. Learn more at maxwelltech.com or connect with us via email at sales@maxwelltech.com.
Let's talk a little bit. So we talked about the behavioral adjustment. How about the PDGM recalibration? So they started using this 2024 data. They kind of, I want to say, refreshed their data a little bit. Any thoughts around that as they were building this rule versus using older data? Historically, they've always used a lot of older data. So any thoughts around that? And then thoughts around the PDGM recalibration around LUPAs and some of the outliers. Any thoughts around that? And as they spent a lot of time in the rule talking about it. Luke, go ahead.
Sure, yeah, I'll jump in. So that has been, something that CMS has chosen to do annually for some time, Tom. And there's, again, I'll revert back to a lot of the comments I read over the last few days when reading the rule. Again, a lot of people just upset commenters, which I assume most are probably agency owners or those that work in home health agencies around the country, are saying it's just tough to keep up, right? We develop a business model, or we have certain types of clinicians to treat certain types of patients. We go to certain types of referral sources based on, a lot of different things. In part, the comments would say based on, what the payment structure is for those types of patients. And then every year you move the cup around, basically, right? You got 10 cups on a table, the ball's under one of them, and it's trying to follow that around the table, and it's just hard, right? And I understand that, I get that. And CMS is saying, they've stated that they do this just to align kind of payments with resource use, which is a really important element that I think a lot of agencies don't understand, that we need to understand, is to ensure that we've got, very accurate and robust cost reports that are out there that we're submitting to CMS. That was a big part of this rule. Scott could probably dive into that, both in advocacy and kind of what came out the proposed and final rule, to make sure that CMS sees the whole picture of what it's costing us to deliver care to the Medicare patients that we're treating, and then how those costs are showing up accurately on the cost report, but that it's that resource use versus the payment that CMS wants to make sure is accurate on a year-by-year basis. And that goes to LUPA thresholds, that goes to outlier thresholds as you set that, but they're basically looking at the data, usually the most recent data set that they can, to develop any tweaks that they feel like are needed to alter a LUPA threshold if they're seeing change in behaviors industry-wide, not specific to any one company or any one provider, but across the industry. Are they seeing enough kind of change to support for them that they need to tweak these things going through? So, overall, from our standpoint, not huge changes here, but definitely can understand why there is some angst and some anger from some of the commenters that they just can't feel like CMS is always moving things around in these areas.
Yeah, Scott, you want to comment on the cost reports?
Yeah, well, I'll comment to cost reports, but also one of the things on the recalibration, because this goes back to the large change that they made and the permanent adjustment for this year is like, what we pointed out in our comments and others did as well was there's a lot of policy changes that have happened, not just PDGM. And so really cutting off the data after 2022 to really say what is or isn't PDGM behavior change. And one of them was, they started recalibrating case mix weights on an annual basis, and how are they separating that out from PDGM related behavior changes to the new payment model. So, I know these kind of seem like small things, but I think the dividends are going to be quite large over time. Look, the reliability of cost reports from agencies across the country. We know through how, I think Luke, we talked about this when HCHB was coming out, some of the shifts that they were making on cost reports and some of the dangers about how they were moving things, and not having accurate cost reports is kind of one of the underlying things that has allowed this system to kind of ebb and flow. That's caused some of the problems that we've had in reimbursement. So I can't stress enough how important it is for any of the providers that are listening out there to really make sure that they are accurately and completing those cost reports with all of the information that's required. Because when they don't, and it could be good providers, but the information gets thrown out or it's part of the trimming process, that's valuable data that's getting tossed out or getting included if it's not done correctly. And that hurts everyone. It doesn't just hurt that provider, it hurts the entire system. So we need to make sure we're having accurate cost reports.
Yeah, it's amazing to me how that's the last thing people want to do, right? It's kind of a pain. It's hard. There's reports that are, been written for the EMRs, but it's like rushed and then they throw them in and then we're being graded on those. And so, yeah, I agree with you. Accurate cost reports are so important. Remember back when LUPAs were just 4 or less episodes or 4 or less visits? Remember back when MO825 was really a number that we all knew what it was? I mean, it's so cheap. That was a long time ago, but then it went to M2200, and now it's, now just figuring out what a LUPA is. I mean, you need technology to figure out if it's a LUPA or not, and it's in the thresholds.
You're dating all of us, Tom.
I know. MO825 was like the first big Oasis number I memorized. So, all right, let's jump into the clinical and operational ripples. Face-to-face flexibility. So they added some face-to-face flexibility in this where we can use, it said any physician, nurse practitioner, PA, or CNS to conduct a face-to-face during a simplified intake. Impact of that. What do you guys think about that one?
Yeah, well, I guess I would caveat it that, Tom, you've assembled the lawyer turned, advocate for the industry and a numbers guy that's still a numbers guy. So, not approaching this from a clinical background, but no, dug into this and understand this. Obviously, work with our clinical lead counterparts on all things, clinical operations here. Look, we'll take any flexibilities that we can get to streamline and to widen the ability for additional providers to be able to perform face-to-face. That's always good, right? And we would continue to advocate to CMS that the least burdensome face-to-face kind of rules and regulations are what we want. And if you go way back to when this was first instituted, that's something that the industry has worked very hard on to make sure that, look, we understand what the guardrails need to be. Let's not make the guardrails any more than they have to be in order to accomplish the goal of instituting those guardrails. So, look, we'll take this. It's definitely a win for the industry, and I think it's going to allow us to work, in a more streamlined fashion with a greater set of providers out there that can perform these face-to-faces. And we'll take more along this line as well if CMS is willing to loosen the rules while not, giving up what they need to maintain in terms of guardrails.
Yeah, I agree with that totally. Scott, anything there?
I'll just say from a policy standpoint, it is a recognition, I think, that CMS is understanding as the the healthcare delivery system evolves and more, non-physician practitioners are interacting with our patients and our agencies, that the regs and the guidance from the agency have to keep updated with that. And I think this is an example of it. We saw when the CARES Act was passed during COVID, a long-standing priority of the industry was to get non-physician practitioners the ability to certify a patient for home health. It took, over a decade for that to happen, but it happened. And that's one of the things I think, allows more access to the benefit, is allowing more people to certify and do face-to-face. And it's good to see CMS, propose and finalize this reg.
Yeah, I mean, I think it's bizarre. I mean, as a guy who practiced medicine in the military for many years, I could do sutures, surgery, pull something out of your eye and all that, but I couldn't certify you for home health. Really? I could prescribe you any medication in the pharmacy and the doctor's orders, and we couldn't give you home health. I mean, that didn't make sense. So I'm glad they finally figured that one out. And I think there's going to be opportunities for organizations to let's lessen the load on the physicians if we can, and let the nurse practitioners and PAs that work for those physicians be able to do the job that they normally would do for all the other businesses, but not just for home health. It's pretty bizarre. All right. They also simplified OASIS a little bit. So they took 4 OASIS items out. Thank goodness they took the COVID ones out. I really want to quit talking about COVID the rest of my life. So they took those out. Anything there that you guys want to talk about? I mean, I know you have to update your EMR. You have to make sure the clinicians are ready to answer the different OASIS questions. But other than that, I think they did they took out the ones that were necessary, correct? Thoughts on that one? Any from a clinical perspective?
Yeah, I'm happy to start there, Tom. I think, I'm with you on COVID. I wish it wouldn't have taken so long to get this out. It's been a burden and just adds time to collect that information, from every patient that we're serving and document that. And with all these, when they're moving around, they're taking away 3 or 4 measures in one area, they're adding 3 or 4 in another, or at least telling us that they're adding 4 the following year, which is the case in this rule. Those are really, peanuts at the end of the day in terms of kind of lightening the load on our clinicians that is way heavier than it needs to be and should be in terms of documentation. And so, I think really what we've got to do is providers in this industry is not only advocate to CMS to make sure that we don't have burden through questions and documentation in other areas that CMS forces on the industry that aren't necessary. But as providers, we also have to figure out how can we take this burden that is mandated on the industry and on our clinicians off of them to the extent that we can do that, right? And that can be working with Home Care Home Base and other, EMRs and other technologies out there to help automate some of these things, to help make recommendations based on, other questions that have been answered elsewhere in an OASIS or any type of format that's being addressed by the clinician in the home. And so that's really, I think, where we have to focus. But this in a vacuum, don't see it as a huge win.
Got anything to add to that?
I mean, the only thing I'll add to it, no, not necessarily a huge win, but it is good to see that CMS is re-examining some of these measures that they don't feel like are adding to either the quality of care that the patient's getting, or they're taking away from, their true care delivery. And so it's good to see that they continue to reassess them. But I agree. I think some of these things are probably, small potatoes, as Luke pointed out. We need to be looking at bigger burden reduction efforts to take it off of our clinicians. So I look forward to working with CMS. And I know this administration's put out a priority to really go after some deregulatory issues, and we're working on that at the Alliance to come up with some recommendations for them to do that. But I'd like to see more than just OASIS simplification.
Yeah, I always try to ask, for what, to do what, and then what. If you're for what are we collecting this data for? And then what are we going to do with that data? And then so I've seen this a lot my whole career. They start asking for, visit times, or they start asking for the number of visits, and they're going to do something with that data, right? They're not just collecting it for some reason. But it is interesting as the administration changes, we kind of get stuck in this, and they replace people in CMS, or they replace people at different levels. And people get promoted, they leave, whatever. We collected all this data back in. Are they going to ever use that data for anything? And if not, why are we still collecting it? And it's amazing to me how much the OASIS, puts a burden on the clinicians. And I don't really know what they do with all that data set. There's a bunch of elements of it that you're like, why? Why are you doing that? I can understand, like, how many medications are you on or something of that nature. Sure, there's value in that, and we can look at that. But there's just some of them that are just make no sense. Let's talk about value-based payments. So they're removing 3 cap measures and adding some new ADL based and cost metrics. Do we think that aligns with the quality and for real patient outcomes and efficiency, or is it just a shift on the forms that we have to fill out? Scott, I'll start with you on that one.
I think with VBP, first, I'll just speak broadly on it. Like, very excited that they continue to want to see home health value-based purchasing as the demo that was successful and saved money. And they keep repeating that it's estimated to save, I think, $3.4 billion over a 3-year period. I still question whether the incentives are there for providers to really achieve that 5% bonus, because it still seems like a lot of providers are in that bell curve that's plus or minus 1% to 2%. So are we truly incentivizing the right type of behavior to go after, the measures there to accurately do it? I know Luke's the operator on this one, and I know that they've been very good at this. So I'll defer to him on whether any of the changes this year actually help achieve, any of those goals.
Yeah, for those, of your listeners that haven't really, looked at this closely, there are some significant changes that are being made to the calculation for the home health value-based purchasing program, in terms of, we've got as much as a 5% increase or decrease in our rates on an annual basis now for providers across the country and participating in this program. And the way that CMS is weighting the measures that make up that, I don't have them right in front of me right now, but there's a number of them, right? I think there's probably 12 or 15, maybe a little bit less than that. But the weight on each one of those that ultimately determines whether you're going to get a rate increase or a rate decrease as compared to your peer group is important, and the changes they're making are significant. And so, for one example I looked at was, if you were doing really well on potentially preventable hospitalizations, that's completely different now. And so you're going to have to figure out, how do you score against your peer group points and other buckets if that's where you were really scoring your points, which was a great one for high quality agencies to capitalize on. But really understanding those changes, how they are going to look in the future versus how they looked in the past, and how you may need to focus your organization differently than you have before to make sure that you're performing well in that program.
Yeah, it's pretty interesting when you start looking at some of the length of stay measures that are out there as well, and around hospitalization. If you have no access to healthcare near a real rural community, you're probably going to be on home health longer because you have nowhere else to go. And that rehospitalization metric has really caused a lot of pain. And I spent a lot of time discussing that with Tracy Dinn at AccentCare and others, especially in these rural communities where the only care that you can get is at home health. I mean, there's nothing else around. You're an hour from the hospital, you're an hour from a clinic, and so those patients tend to stay on service for longer. Then they get the agencies get penalized because they have a rehospitalization because you've been on service for 180 days versus a 60-day or 30 days in an urban community. So I think they need to look at that a little bit more. But you're right, Luke. Most people are not looking at value-based payments like they should. They need to go in and understand those weights and understand where they need to train their clinicians and put double checks and triple checks in their EMR, or put validations in their EMR to make sure that they're clinically documenting appropriately. If not, they're going to get penalized. And you thought you got a 1.3% rate cut. Now you got a 7% rate cut because they added 5% more on top of it. Pay attention. So for the listeners out there, if you need help with that, call us or call Luke. He's one of the experts in it. We'd also like to thank our episode sponsor, Levo, a company that's changing the way home health and hospice organizations approach staffing. Levo's platform streamlines recruitment by working around the clock in the background, helping agencies connect with the right candidates faster. It also uses data-driven insights to identify potential employee challenges before they turn into preventable turnover. And the impact is clear. Organizations using Levo have seen time to fill drop as much as 40% and retention improve by 20%, all within that first 6 months. To learn more, visit hellolevo.com and be sure to tell them that I sent you. Let's talk about visit patterns. With these rate pressures intensifying, how should agencies recalibrate visit patterns or visit frequencies as you think about, should you front load visits? Should you spread them out evenly? Thoughts around that, Luke, as an operator? And I know it's different for every patient, but as you start giving guidance to clinicians around how do we manage this stuff, what are your thoughts around that?
Yeah, this is definitely a challenge for providers and operators, Tom, because at the end of the day, we're going to provide, and I trust most all providers across the country, and your listeners the same way. We've got to figure out how to provide clinically appropriate care on a patient by patient basis to achieve the outcomes and goals set, in that care plan with that patient and overseeing physician and the agency providing care. And so that can take a number of forms, right? Within that, to the point of the question, there's different ways to achieve those goals. There's different ways to provide that clinically appropriate care. I wish that providers had more um, ways to do that, right? If CMS allowed in the rules for us to use telehealth more to get reimbursed for some of our own patient monitoring, elements, absolutely. I wish we could have more arrows in our care delivery quiver, if you will, as home health providers to develop, highly innovative care programs that aren't just singularly kind of focused around in-person human-to-human interaction visits, right? Which it is today because of the way that the payment model is structured. That's a significant limiter on how you can provide care within the benefit. But I think we just got to look at that. And I think there was a comment I read in the rule that there's a self-fulfilling prophecy that every year, CMS cuts the industry, or at least it's been that way for a while now, and every year visits decline on a per patient basis. And the commenter was basically like, "What do you expect? Right? We have less money than we had last year. We have this. We can't cut costs, right? We've done that before, and now our labor costs are going up at the same time, right? We've got to give our people, raises or bonuses or others, or equip them with more tools, and they didn't have before to retain them and to attract them to our agency. So push has to come to shove somewhere if you're going to keep cutting it. So I get that, and there's that frustration is felt around the industry. But at the end of the day, we know we can't stop delivering clinically appropriate care on a patient by patient basis. We've just got to figure out what's the best way to do that within the financial constraints that we're being placed under from these rules and from Medicare Advantage payers and all the other things that we deal with as providers.
Yeah, it's well said. It blows my mind that I can call my doctor and he can prescribe any narcotic or anything that he needs to over telehealth, telemonitoring, visit in Minnesota to Scottsdale, but we can't do a telehealth visit for a home health patient in rural community. I got to get in a car and drive for an hour.
You can do it. You just don't get paid for it. It doesn't count towards your loop.
That's right. Yeah. That makes a lot of sense, Scott. But you're right. Scott's absolutely right. You could do it all you want. You just don't. You're gonna have a lot more lupus, and it's gonna happen.
Tom, I think it brings up a valid point that if we think about like 2017 when HCHB came out and the construct of it, it was to move away from volume-based reimbursement to one that aligned reimbursement with the resources needed based upon the clinical characteristics of the patient. And I think that should be agnostic to some extent of where the care delivery occurs. So if it's something where we can use telehealth or remote patient monitoring and the resources are needed for it, it should be reimbursed. And I'd love for us to get to that next level of discourse with CMS and with Congress to be able to, for this industry to be able to take advantage of some of those. And that's one of the things that we have on our future planning. But I do think, again, going back to like the big takeaway from the rule, hopefully we're off of that hamster wheel of they cut us and then we do less and then they say, oh, you did less and now they're going to cut you again, by the fact that they've stopped, collecting that or using data potentially after 2022, that we're not going to continue to go through that. So hopefully we are at that level now where we're going to rebound and be able to really take advantage of what home-based care should be able to do.
Scott, how much of the credit do you take for that? I mean, you guys did a lot of work around, I know you had multiple lawyers working on data and really trying to show CMS that they needed to use more accurate data or more real-time data in order to make these analysis.
Yeah,
I mean, take some credit for that.
Yeah, I mean, look, I'll say it's a proud moment for the Alliance to be able to lead on this particular issue. It's a very technical argument that was made and advanced, and it was helpful to have our members get a preview of it and support it. And we had a very collaborative process and robust process leading up to our comment letter submission, where members like Luke were able to listen in on some discussions and provide feedback and know where we were going on some of our arguments. But it is one that I think really, as we get, more and more opportunity to talk to people about that final rule and what the change was, being able to show that this was a big argument that was made and advanced, and proud that our team was able to do it. And I mean, it was a team effort for sure, both internally with our team, with Hillary Loeffler, who's our VP of Public Policy and Regulatory Affairs, really leading our comment letter process, working with the rest of our team and the analytics team and some of the contractors that we work with, but and also learning from the past. I mean, there were some arguments we made in the past that we doubled down on and just provided more data because CMS had to give us more data this year in the prep for the comments, based upon a law that was passed by Congress in 2022, where we got to see a little bit more of how CMS made their rate files. So definitely team effort, but it was good to see the Alliance team and the comments that were made, and us leading the way. And thankful for Dr. Landers, our CEO, allowing us the opportunity to do some of these things a little different.
Tom, if I can, I would just add to that briefly. Just it's huge, right? And kudos to that whole team, Dr. Landers, Scott, Hillary, the rest, everybody there. But we've been trying to do this as an industry. Scott I can remember being in the trenches. He's referenced HCHB, the home health grouping model that was here, the predecessor to PDGM that was proposed. But when this cut got proposed to hit us even before we go into PDGM in 2020, because they know we're going to change our behaviors as an industry and game the system. We've been trying to argue against this since 2018, 2019. And it's been argued every year since then. So, all the kudos to the Alliance and the team there and the effort that was made this year by everybody, because this is a monumental shift and hopefully a huge long-term win for the industry that, as we've achieved success this year on.
Yeah, absolutely, Luke. And thank you for your help with, getting the EMRs to push data together as well as we were doing analysis. I know WellSky, NetSmart, HomeCare Homebase, Luke was really involved in that. Trella push data together. I mean, there was a lot of work done around that. And Bruce was leading a lot of that work as well. And that mattered, right? We were able to really take data and show it and work. And so, just shout out to those guys to keep doing that. Like, we don't want to share the wrong data, but let's all get the right data together and make decisions around that. So shout out to them on that. Let's jump into the fixed dollar loss ratio. Most people don't know what that means. So, but it keeps the outliers at a 2.5% of spending. How will that affect agencies that are managing these really complex, sick patients? Luke, I'll start with you because I know you guys have spent a lot of time on outliers in my career with you.
Yeah, we have, Tom. Going back, this wouldn't be in place if we didn't have, that hotspot in the country back, 15, 17 years ago that was experiencing rampant, escalation in the treatment and billing of outlier patients. And, when the outlier cap came into rule, it was really a blunt instrument that CMS implemented to really address a singular hotspot in the whole country that impacted the whole industry. And we've been living with this since then. I think the key element here, though, Tom, not to go too far back into history, but is that the rule for CMS is that they have to set this fixed dollar loss ratio, and it's really the combination of the FDL and the cost sharing ratio on the 80% that basically share. I get a 20% loss from the per visit rate for every visit we as providers exceed over that outlier threshold. There's a balance between the two, but they haven't really changed the 80% cost sharing for quite some time. But on the FDL, the fixed dollar loss ratio, CMS really has to set that at a level such that outlier payments do not exceed 2.5%. And so I wish it was that it had to equal 2.5%, because right now that gives CMS the ability to set it at a rate with, maybe a whole lot of cushion to make sure it doesn't exceed versus maybe a little bit of cushion on the exact science to get it right at 2.5%. And so I think, there was definitely some advocacy work. Scott may be able to speak to that, this year, and there has been in the past as well, to try to make sure that number wasn't moved in too large of a fashion, to make sure we didn't exceed 2.5%. But yeah, this is tough, right? I mean, this impacts every provider in the country by -0.1% this year. And really what it means is that it's just going to, fewer patients will get in to be an outlier, is really what that means at the end of the day. So I'll let Scott maybe go on beyond there. But yeah, definitely a pretty technical issue that, impacts those providers that are caring for that complex patient care population and others that need a much larger number of visits than the average patient does.
Yeah, I think the only thing I'll add, Luke, is that, Tom, if you want to go deep on this, I have the right person for you to do it. It's just not me. Hillary Loeffler knows this policy backwards and forwards and can give a real good dive into how the FDL policy came in. And then some of we definitely advocated for some changes. So it's good to see that, they did what they did.
Yeah, I think it's one of the most complex things that they've done over the years. And the one that scared us the most way back when, because these are your really, really, really sick patients. These are your 40, 50, 55, 60 visit patients where we're going every single day. We have major, diabetic, major comorbidities, major problems. And these patients really need it. I mean, without us doing this, kind of daily visits for these patients, they're back in the nursing home or back in the hospital. They're in ICU, and they're going to waste all the government's money. So,
hey, this is Alex with StenoHealth. Our mission at Steno is simple: to improve the quality of life of the post-acute care clinician. Steno uses ethical, compliant AI to capture visits in real time and turn natural conversations into accurate notes and forms. We are clinicians ourselves, and we've designed Steno to never feel like an extra click or an extra burden in your day. The goal isn't to replace anything, but to support you in every aspect of your day so you can spend more time with your patients and still have the energy and freedom to be present with your family at the end of the day.
All right, budgeting and forecasting. So as leadership teams are right in the middle of their budget process, hopefully they're already halfway through it. They're just waiting for this rule to come out so they can adjust it. Should they plug in the 1.3%, or should they go look at their wage indexes and try to figure out what the real cuts are and balance that by branch? And I don't know, Luke, I know you and April are deep into the budget season right now and trying to get it approved. What's your guidance around this rule and the things that came out around it?
Yeah, Tom, all the above, right? I think that you've got to look at your own unique agency or groups of agencies, right? For VitalCaring, that means across multiple states and in number 10, 55, 56 home health locations that this rule is going to impact. We're budgeting at a branch specific basis, right? At an agency specific basis. And so in order to align the expectations for a budget with what actually is going to occur next year, that's got to be really specific. So it's got to take into wage index. It's got to take into unique case mix changes that are impacting the unique case mix that each of those agencies that form VitalCaring, have as patient populations there. And so it's really all the elements of the rule that come in. And for us, as I made a brief comment earlier, we've got an agency in Florida that's getting a 10% wage index increase, right? And we've got one in West Texas that is getting a 5% cut, kind of the max that you can get on a year-by-year basis. And so that's, we need to budget accurately, right? And in all of those elements that make up that payment rate. So you've got to look at that. Obviously, you've got to look at your labor. Labor is unique to markets and states. It's different and not uniform across all markets. And so looking at that, looking at other payers you've got other than Medicare and kind of what changes you're expecting coming into next year. So yeah, it's definitely hopefully nearing the end of budget season because we're nearing the end of the year here and we're all waiting on this rule. But it's an all of the above approach.
Yeah, and thanks to the government being shut down and the rule getting delayed. And by the way, I'm going to correct myself. On a few podcasts ago, I said that they had to give us the rule by 11/3 to give us 60 days to implement it, and that's what we always thought for years and years and years. Scott corrected me on a phone call, I don't know, a couple of weeks ago, and said by law they don't have to do that. So they tried to give us 60 days to implement from a technology perspective and anything in the changes of the rule, but they don't have to give it to us by 60 days prior to January 1st. So Scott, I don't know if you want to comment on that. You quickly corrected me, and I was, for 20 years, I was incorrect on that rule, by the way.
And I was right with you on that interpretation. I think we've always assumed that it was statutorily required 60 days before implementation, because CMS has that obligation under other payment systems. They've always tried to uniformly do 60 days prior to implementation. There are some abilities to challenge if it's less than 60 days under the Congressional Review Act. That's a very complex process. We've been told that it's really 30 days to make sure they comply with the Administrative Procedures Act. But even that, with the government shutdown, they have good cause waivers and other stuff that they can do. So, they got it out about as late as they probably could have. But it's also, I think it's the latest it's ever come out. But, definitely learned some on that. For every other rule we've seen, though, it's always been closer to that 60 days, with the exception, I think, of 2014 when there was another shutdown. It was, right around Thanksgiving time, maybe a little earlier than it came out this year.
Yeah, I'm sure AT&T got a over influx of text messages to Scott, everybody asking him when the hell the rule is coming out, because I was one of those guys, and I know Luke was, and everybody else. So he's probably got.
I made a comment that everybody kept asking, was like, maybe it's today, and there's the old saying that a broken clock is wrong at least twice a day. So at some point I was getting right.
Yeah. All right. Let's talk about so 1.3% cut. What do we think this does to the industry as smaller agencies, especially with the value-based care payments coming out? It's going to be harder and harder to get, better at that. What do we think that, still getting a cut year over year, getting cuts from CMS? Do we think this is going to cause more consolidation? Do we think this is going to cause agencies to, struggle more? Thoughts around, acquisitions, roll up, and we'll start with Luke because he's doing acquisitions in both home health and hospice. So thoughts around that?
Sure, Tom. Yeah. So as you said, through my role here, I see a lot of acquisition opportunities, and a lot of those are smaller. To the point of your question, agencies out there, and it's a wide mix still. I mean, there are still smaller agencies that are performing very well today. Right? They've been able to manage their payer mix well. They have great relationships with one or two hospitals in the single market that they where they operate. They've got a very loyal workforce because they've got a great culture. And so there's still pockets of those that are doing well, but the fact pattern alone of all that you kind of laid out definitely favors scale, right? Because for us, we've got some agencies that get a positive wage index, impact versus those that don't. And if your only agency is the one that gets a 5% cut on your wage index, and you don't have any other agencies to spread that cut out with some wins in some other markets, then that's just what it is. It's a cut for your agency. Scale, right? I know from experience, you can get better pricing with vendors, right? And with partners that you have to have in this space. From a health insurance standpoint, you can, be self-insured. There's things you can control costs more on the benefits for your employees with scale. And, I could go on with, contracting with Medicare Advantage payers and the like, that definitely favors scale, but it doesn't mean that there's not room for the smaller providers to still, perform really well, even dealing with all the same challenges the larger providers are, but they've really got to have some unique things going in their way, and they've got to have a high performing culture really to achieve success.
Yeah, that's well said. Scott, you want to add to that?
Just to add that quality providers that have good relationships with their referral partners, with their hospitals, I think, are able to withstand some of these challenges. And I hate to keep going back, but I hope that, even though we're having this cut for this year, that the future, we can do a little bit longer term planning, and they can see that, things are going to turn around. That's my hope. So, for those high performing smaller providers that are spread out throughout the country, I still think that there is a role, and that they will be able to excel and succeed.
Yeah, I was in a board meeting a couple of weeks ago with the Tango team, and this guy's dad needed care in upper state New York, and there's one home health provider in upstate New York in this town he was at. I can't remember the town. So I pulled up Trello data and I was looking for it and everything. And I mean, literally, he's in the island, and then one provider was a government funded, local city provider, and they were like, "We can't take your dad. Sorry, we have nobody." And it's really scary. And he's like, "What do I do?" And I'm like, "You got to go find a nurse, hire that nurse." I mean, luckily this guy had the resources to do it, but there was nobody that could take his dad, and they wouldn't discharge you from the hospital until you had home health. He's sitting in the hospital for 5 days longer than he should have because they couldn't find a single person to take care of him. And I'm calling, Bayard, I'm calling everybody trying to figure out where it's at, and nobody could take him. I mean, nobody's like that. We don't service that part of upstate New York. It blew my mind that there was no providers there. So anyway, wild. Let's start talking about recruiting. So as this new rule comes out, we need to grow. We need to grow those areas, like Luke said, where you have an increase recruiting. I'm working with Levo right now. We're doing a big benchmarking process so we can benchmark time to fill jobs, recruiting, turnover, all those kind of things, and get a national benchmark together. Any thoughts around what Luke? What are you guys doing on the recruiting side, and how do we get more clinicians to come into the home health and space?
Yeah, I mean, it's huge, right? I mean, I think that for any agency that's looking to grow, which, our organization definitely is, then you've got to recruit because you need to grow your team. And then, we also have a huge focus on retention, so that we can reduce the amount of recruiting we need to do if we can keep, the team members that we have on the team today. So that's, yes, we've grown our recruiting team significantly. We've tried to get our brand out there more, Tom. We try to really kind of bring to life through videos and ads and different things that we put out there, mailings, kind of what the culture, what it is, really a day in the life of a VitalCaring team member, and hopefully attracting the right people out there that are considering a change, and get them on board and then retaining them. So I could spend a lot of time talking about that because that's a huge focus for us, especially as a newer brand out there, only a few years old in the space. And so spent a lot of time thinking and then executing on, how we can improve in that area.
Scott, what are you guys doing to help advocacy around nurses and, teaching nursing schools that, home health is actually the best place for a nurse to be?
Yeah, the Alliance, we're in the process of rolling out an image campaign that really focuses on what being in the home-based care setting looks like targeting clinicians to make sure people understand, what those opportunities exist, where they are, and the growing demand, and why we need it. So that's something that we're in the process of rolling out, and so stay tuned. Again, people go to our website and sign up for some of these alerts. You'll see more about the image campaign that's coming out, and that's where we're trying to really push the recruitment for more clinicians.
That's awesome.
Yeah.
Yeah, I want to get behind that as well. I think there's a need for it, and it's crazy. I was part of a home health agency out in California, and we posted on our Indeed site that you had to have 7 years of experience in hospice to apply for a job. We get no applications. Nobody wanted to apply. Nobody had 7 years experience. We took that piece of it off. We got hundreds of applications. So, and then when you start talking to people, they're like, well, home health's too hard. It's too much paperwork. It's this, it's that. I go, it's not harder than working in a hospital and, in ICU. And we get to know our patients, and we get to fall in love with our patients, and we see them for a long period of time. And you get the same patients over and over and over. And those are the stories that people need to tell. And it's pretty amazing when you sit down with home health nurses that have been in this industry for a long time. That's what they fell in love with, right? And the last thing they want to do is go back to the ER or the OR. I mean, I was an ER PA and I loved it, but it was high stress. But 30 minutes after that patient went upstairs, I never knew what happened to him again. In our world, we're following that patient all the way to maybe to their end of life. And so I think if we can get that story out there more and get more advocacy around that, I think it's going to be super important. We have to grow this industry. Everybody that I know in this space is looking to hire. I don't know anybody that's saying, I don't need 10 more nurses or 100 more nurses. And you go look at the job postings, there's hundreds and hundreds of them out there. So how do we convince people that don't understand home health or hospice to come into home health and hospice? It's important. Thanks for doing that. All right, well, let's wrap up. The show's called The Last Visit First. After digesting the final rule and what just happened to us and getting a rate cut and all that, what does that mean to you guys? What does it mean? What does the last visit first mean to you? Start with you, Luke.
Yeah, Tom, I just think that, really what I reflect on in moments like this, right? So Scott and I have been in the trenches a lot, you and I, Tom, as well. I love the colleagues I've worked with over the decades. I can say that now that I've worked in the industry. And we're working hard, right? We're working long hours. We're, on the road a lot. We're doing things that have to be done in order to try to accomplish the goals that we've got in front of us. And that can be grueling. But I always find at the end of like a process like this, you've got a huge rate cut staring at you, right? You know what that means when you run the numbers through a spreadsheet for your company, for your agency, and you advocate hard. You put in a lot of time and effort to do that, and then you kind of reflect on what happened. And I always think, well, why did I go through all that? Well, really went through all of that because the heart and soul of this industry is what happens, in human interactions in a home. All right, between our clinicians and the patients that we are entrusted to treat, that are referred our way, right? That and their families that trust us to be there, that trust us to deliver high quality care, to trust us to, to be reliable. And I think that's why we do what we do, right? Because we're really here. I'm really here to support what's happening in the home and what's happening in each of our branches. That's what's supporting what's happening in the home, right? And organizing that and scheduling it and on all those things that are occurring. And, once you do a few home visits in this space, right, and you get ride-alongs and you see what's really happening, to your point, just like that home health or hospice nurse that left the ER or OR and came into the space and fell in love with it, the same can happen even if you're not a clinician in this space. And once that happens to you, I think that fuels you to go above and beyond, do everything you possibly can, and whatever your role is. If it's not that, you're doing something to support what's going on in the home, and that's what we're here to do. And working hard to try to achieve the best outcomes we can here to support, ultimately, again, just the fabric of this industry is what's happening in the home.
It's awesome. Well said. Scott?
Look, the way I look at, where we are right now and what happened in this final rule, I mean, I would like to think, knowing what we were faced with, that we've given breathing room for agencies that saved jobs. They saved patients who were otherwise going to be in a service area that may not have existed anymore. We've allowed agencies to maybe do a little bit of growth that they were planning to retract for next year. So maybe there's an investment that's happening in some sort of technology that's allowing them. But at the end of the day, I think, as Luke was talking about, this is about the people. It's about our clinicians and the patients that they serve and the families. And from the Alliance's standpoint, being able to be advocates to help spread the message about what home-based care is able to do. It's a kitchen table issue that all of our families have either faced or will be facing. I know from an education standpoint, when I started in medicine, I didn't know a whole lot about home-based care, but as I got to learn about it, I realized that, 3 of my 4 grandparents had all received high quality home-based care, whether it was home health, personal care services, and ultimately 3 of the 4 died at home on hospice. And that was because there's investments made into the system, into Medicare, and that's one that we got to keep. And, advocacy processes like this allows us to do that. And I just feel that the process that we just went through, I would like to think helped save some clinicians some jobs, helped allow access to be expanded maybe a little bit or a little less constrained. And, at the end of the day, we feel good about that, but there's so much more to do. And I just look forward to, Tom, working with you and your team and Luke and all of our member operators that are out there bringing their expertise to help us continue down this road, because we do have more to do. We're not, at the end of the road, but there's light at the end of the tunnel now.
Yeah. Thank you, guys. Both of you, gentlemen, you're both the experts in the industry, and thank you. Our listeners are going to enjoy the heck out of this, and really appreciating you spending an hour of your time with me and going through all that. It's awesome.
Appreciate it, Tom. Happy to do it.
I'm here. Thanks, Tom. It was fun.
Thank you. Luke,
You
good
bet.
to see you.
All right. Bye-bye. All right. I just want to wrap up this podcast with a big thank you to the Alliance for allowing Scott Levy. Big thank you to April Anthony for allowing Luke James to come on and deep dive into the final rule. If you're out there, you're struggling, a lot of things were talked about today. And if you're out there and struggling in any way, if we could be of help, reach out to Maxwell TEC. We can help explain the rule to you. We can help you with the wage index analysis. We can help you with, how you're going to mitigate some of these cuts and strategies. Also around the value-based care stuff, I think it's really important for providers to really understand that. So if that's an area where you need help, please reach out. Jay, Jen, Tom, one of us will help you. You can reach us at info@maxwelltech.com or sales@maxwelltech.com. Really appreciate our sponsors. Be excited to see the project we're working on with Levo. We're doing a benchmarking project around allowing you to benchmark for your time to fill of your recruiting, also around turnover, around tenure, lots of things like that. So we'll be collecting data from agencies and putting those together and creating a national benchmark, kind of like what we have for rehospitalization, those kind of things, but really focusing around the recruiting side of it. So take a look at that. And we'll be talking about that more in the next few episodes. Thank you again for subscribing, and thank you again to our sponsors.